تعالوا انتوا الاثنين بس شويه الاثنين. انا متاكد راح تجيبوا ولد من Today we're going to start our lectures about the endocrine pharmacology. These will be 7 lectures covering most of the topics. And as usually, as your target organ is producing that target hormone. But what if you don't have the target hormone? You cannot synthesize it, or it's not available as a pharmacological option. You might go upstream and go to the tropic hormone and use it. But that requires one condition, and that is what? Exactly.
Functional target.
This target organ is functioning well and functioning properly so that it could produce this target hormone. Now, into the hypothalamus and the long loop from the target organ into the hypothalamus. This is called the negative feedback mechanism or the feedback inhibition. Now, another interesting thing about this system is that we might also have another loop of inhibition coming from upstream, okay? Which means that the hypothalamus is not always secreting releasing hormone. It sometimes secretes an inhibitory hormone or a release inhibiting hormone. And that's called the feed-forward inhibition. Okay? How could you use that in pharmacology? Simply, the negative feedback loops could be used for diagnostic purposes. As I said before, I could give this tropic hormone from the anterior pituitary. أنا مش شغال. في حدا معه ليزر؟
صاروا له بطارية دكتور.
طيب, I could use this hormone from the anterior pituitary and see whether it inhibits the elevated levels of the releasing hormone. So these could be used for diagnostic. Exactly. So we could use it in the other type of treatment, which is the suppressive therapy, when there is an increase in this target hormone or this tropic hormone coming from the anterior pituitary. Now, the third concept we have to mention, and it's very interesting, it's the pulsatile release or the effect. It's related to the day-night cycle, okay, which is most commonly caused by this change in the biological clock in your body, but that's the only factor that defines this pulsatile release. There's also the environmental factors, including mostly the mood status of the individual, that could affect such pulsatile release of hormone. Okay? Now, this is evident all over the endocrine system. It could be related to age, and we have hormones that are modeled in their secretion according to the age of the individual. It's evident also in the females when it's related to the days of the month. And it could also be explained by the presence of an opposing mechanism or an opposing hormone to the action of the first hormone, something we call the counter-regulatory mechanisms of the endocrine system. In all cases, the bottom line, why am I mentioning that? It's the general concept of endocrinology that therapeutic regimens in lots of conditions need to simulate the normal circadian rhythm of secretion of that hormone you are targeting. If you don't do it, then you might affect the endogenous type of secretion from the body, and that hormone might not produce the effects you want in the patient. Okay? So you have to have some knowledge of the physiology of the secretion of that hormone you are giving to your patient. Now, the fourth concept is that most of these hormones in the hypothalamus anterior pituitary axis, they are peptides or low molecular weight proteins. For example, if we look at the growth hormone, it's a very small one. and also in the prolactin. But the question is, so what? Who cares? Now, the first thing that we care about, and out of this concept, is the fact that these are found mostly in trace amounts and will have local effects within the vicinity or the neighborhood of that secreting cell. Okay? Again, so what? Now, so what? It's hard to identify initially, it's hard to purify, and it's hard to chemically synthesize these hormones. And it's not a strange fact that endocrinology as a knowledge or as a science was discovered just recently. And I'm going to give you the story of that in the urogenital system next term. You will see that it's a recent advancement in the knowledge and in the science. And it's all related to this fact. It was very hard to purify and identify and chemically synthesize these hormones. And that made most of the endocrinological diseases fatal in the beginning. Can you imagine that diabetes was extremely fatal when it was first recognized as a disease, until they were able to identify insulin and identify that it's responsible for this disease, and then purify it and synthesize it in commercial sizes to be given to the patient. Now, the other thing that's important for us as clinicians is the fact that these peptides, if they are given orally, then there is a huge chance that they will be hydrolyzed as soon as they get into the GI by the peptidases and proteinases, or proteases. Okay? Another thing is that once they get into the intestine, the absorption will be severely impaired, or there will be no absorption for these compounds if they get into the intestine. Which means that you cannot give them orally in most of the cases unless you do something magical to their structure. And that means that most of these hormones we're going to discuss today are given by injection, the several routes of parenteral injections, and that means you have to deal with the fears, with the phobias of the patients, with the refusal of certain patients to take such drugs. Now, the anterior pituitary hormones, as you know, we have the TSH, and this will be discussed further in the thyroid lecture next week. ACTH will be discussed in the adrenals lecture the week after, and then we have the LH and FSH. I'm going to discuss these next term, inshallah. And today our lecture will be limited to the growth hormone and the prolactin systems. Okay? So by the end of these two terms, I'm expecting you to be well aware of the endocrinology in general. Okay? Any questions about these concepts? أبداً؟ The growth hormone system. Let's go over the general organization of this system, and we know that there is the growth hormone releasing hormone from the hypothalamus, which leads to the synthesis and secretion of the growth hormone. And most of the actions of the growth hormone could be done directly by the hormone on the cells. Okay? But nonetheless, we know that growth hormone could also produce certain mediators to prolong its action and to sustain its actions. And these come mostly from the liver, but they're not exclusive for the liver. And these are called what? Somatomedins, or the insulin growth factors 1 and 2. Insulin growth factor, or insulin-like growth factors, it means that they are structurally related to insulin, which means that they could also bind to insulin receptors, and they could also produce insulin-like effects, which is counterintuitive, as you will see in a minute. So, the function of that, it's literally a growth hormone. It's important to know that they induce the cell proliferation and replication and positive nitrogen balance. and inside the cell they induce the protein synthesis, the lipolysis, and the hepatic glucose output. Okay? In general, that leads to the growth of bone. Okay? Now, which one of these are directly produced by the growth hormone, and which of these are mediated by somatomedians? It's not very well identified. Okay? Just for the fun of science. As you can see that the growth hormone induces lipolysis and hepatic glucose output, okay? But on the other hand, you know that insulin induces what? Lipogenesis, or you will see. Lipogenesis, and it increases the uptake of glucose into the cells. So these are counter-regulatory. How does that work? Now, from that, we know for sure that some of the functions of the growth hormone are only done directly by the growth hormone. For example, like the cartilage growth, or the bone growth, or the increase in the lean body mass. Most of the time, they are produced directly by the growth hormone. But some others could be mediated by somatomedians. Now, since it's literally a growth hormone, this is evident in its pulsatile release, or not pulsatile, let me say the modal release of that hormone throughout the years. It increases during the childhood and early adulthood, and then plateaus and goes down later on in life. And that made people think that this hormone could be the anti-aging elixir. Right? Since it's the anti-aging elixir, then a lot of people will be abusing it. And the population in particular that abused it mostly are athletes. Okay? And we're going to go over that in a minute. Now, plus that modal secretion of the growth hormone, it has a circadian rhythm during the day-night cycle. And it's important to know that it increases during the early hours of the night, with one condition, that the individual is having a deep sleep. Okay? Which means what? That if the patient is having insomnia, that surge of secretion of the growth hormone will not take place. Okay? Which means that it will affect his or her growth. So this is something you have to know. Now, just like this whole system, it has both the negative feedback loops, okay, coming from the somatomedians into the growth hormone and then back into the releasing hormone. But at the same time, we also have the feed-forward inhibitory loop, which comes from the presence of, or the secretion of somatostatin, particularly from the hypothalamus, and then it will go and inhibit the whole system. Okay? So that means it could be used in suppressive therapy. But again, since it's the same system, the same concept, we have the cases of deficiency of the secretion of that growth hormone or any part of that axis, and this is called what? شو اسمه هذا الdeficiency? اسمه pituitary dwarfism. Okay? So it could be responsible for the short stature of the patient, it could be responsible for the stunted growth of that individual. But at the same time, we have cases of excess of the growth hormone, and it depends on the age of the onset. We might have the gigantism cases versus the acromegaly cases. Okay? Depending on when that excess happened in the patient. You know this, right? طيب, let's start from upstream and go down. the growth hormone releasing hormone. If it's available for you in pharmacology, how could you use it and where could you use it?
Diagnostic procedure.
So you want to use it in therapy as a treatment option. Again, the concept is the concept. We said that this is most commonly used in diagnostic purposes. So where in diagnostic purposes would you use it? Yes? Okay. Okay. So if you give it and there is an increase in the growth hormone levels, that means that the problem is from the hypothalamus and not from the pituitary. The pituitary is properly functioning and there is no problem. Now, the problem is that it's a short peptide. It's used for research only, and that's because it has a very short half-life. Even when you give it IV, it's hydrolyzed within a few minutes. Okay? In such cases, we also produce analogs. Okay? And these analogs, this is the first one and the most commonly used one, which is called sermorelin. And it's a fragment of that hormone, and it's used like 90% of the cases for diagnostic purposes only. Again, as your colleague explained. Type. And I will go back to you. If you want to use it in the treatment, where would you use it? Hyposecretion from the hypothalamus. Okay, so that means that the pituitary is properly functioning. I might give it. So what case or what's the disease in the patient you're going to be targeting?
Dwarfism?
Dwarfism or growth hormone deficiency. But that's only, as we discussed, it's if the pituitary is functioning well. Otherwise, it cannot be used. But would you use it as a first choice in such cases? No. Since you have the target hormone or the tropic hormone, why would you go for the upstream effective? Okay? So it's a recent introduction into the guidelines, but when everything fails, you might give it a try. Now, the problem with that is that it was used for doping purposes by athletes, and it's currently one of the things that are tested for athletes frequently to see whether they take such doping drugs. What do you think the major problem that happens to these patients or to these athletes when they take the growth hormone or the growth hormone releasing hormone frequently? What is the major problem? So what? It's an anti-aging. Give it, it will increase their lean body mass, it might increase their metabolism and anabolism, so what? Yeah. So what, again? They will stop it for a while and then the receptors will be back. Why are we afraid of giving that to patients frequently? Yes. Exactly. Now, as we will discuss next week, the glucose metabolism is regulated tightly by the insulin itself and the counter-regulatory mechanism. Growth hormone is one of the counter-regulatory hormones against the actions of insulin. So most of these athletes, when they started using this drug or the next drug, the growth hormone itself, they had abnormalities in their glucose metabolism and they were susceptible to the development of diabetes. Okay? Yeah. How bad it is. Diabetes is solved magically by giving insulin, life will be great. But no. Of course. This is something, yeah, this is a good question. Thanks. When you give something exogenously, you have to know that it will affect the endogenous production of that hormone. This is first. And the second thing, if you stop it abruptly or suddenly, that's going to mess up the whole system. Because the endogenous organs producing that hormone will be atrophied or having rest and a vacation. They're not working at all. And all of a sudden, you're asking them to be active again. We're going to give that a hard look when we discuss the corticosteroids next week, inshallah.
Doctor,
Yes.
they may increase the risk for cancer.
معلى صوتك يا مالك.
ايه؟
معلى صوتك.
الكل يسمع. أكيد إنه الجروث هرمون if taken in excess or over يعني dose يعني it may increase certain risk for malignancy صح؟ ما بنخاف عنها على الأقل.
Now, the recent meta-analysis are not very definitive for the risk of malignancies with the growth hormone. The only thing that is proven 100% that it's an inducer of diabetes. Malignancies, it's equivalent. Some results might say yes, some results said no. But that's not a big deal in our clinical practice. The one that we deal most of the time with is the growth hormone itself. And it's important, and it should be common to your knowledge, that when you mention the growth hormone, you have to mention this guy. صح؟ تعرف انت؟ انه هذا اخذ growth hormone؟ طيب. This is Lionel Messi. Now, first off, the growth hormone in the beginnings, when they actually identified it, they started purifying it and taking it from animals and using it for human uses. But the problem is that it was too antigenic and it was not effective in humans. So the only advancement that spurred this field of growth hormone treatment was the introduction of the recombinant DNA technology. At that time, we were able to synthesize the human growth hormone itself, okay, from this recombinant technology, and we could use it. Now, the drug we know now is somatropin. You know, growth hormone is called somatotropin, so this is easy to remember, somatropin. And as you could see, it's going to be given by injections, but the important thing is that it's given in growth hormone deficiency. Now, this is Messi when he was younger in Argentina, and he was diagnosed with this growth hormone deficiency, and that's why he was indicated to take these injections. طيب. بس نرجع للصورة. Now, in addition to that, a recent advancement also in the guidelines says that you could use the growth hormone in chronic wasting conditions. Like what? And why? Yes.
كشخصية
Cachexia in general, yeah, which is the wasting thing. Like in the cases of يعني starvation, طعام. Like in the cases of AIDS, like in the cases of cancer, this chronic cachexia and wasting, you could use the growth hormone. And the only thing that you are targeting by using the growth hormone is what? Is the increase in the lean body mass and the growth of the bone. Okay? So, which means that strengthening the patient. Now, the problem with this is that it has to be used 3 to 7 times per month, and that is extremely expensive. Okay? فبالتالي Barcelona fans should not be very proud of themselves. The only reason that Messi moved to Barcelona was the fact that they offered him the growth hormone treatment. Okay? So they took him from his club in Argentina and paid for the growth hormone treatment, and that's why he moved to Barcelona. Now,
لا دكتور مش استراوي
there is another indication, which is the normal short stature. شو يعني normal short stature؟
يعني إذا في زي البليت صار
ايه per week. Normal short stature. This is another indication, and it's also recent one. Yeah. Exactly. So there is something we call the constitutional short stature, or in other terms, the normal short stature. The growth hormone levels in the patient are okay, are good, within normal range. So it's not 100% proven, but a study, a big clinical study, was done over these individuals, and achieving the supraphysiological levels of the growth hormone could increase the lean body mass and bone growth, okay, and might give them a few centimeters or something, okay? But is it like 100% proven fact that if you give it for these patients, they're going to improve? Not really. But it's a nice story. Now, since this was very frequent, 7 times per week, up to 7 times per week, and it's very expensive, now we have the depot preparations, so you could use it once or twice per month, which cut the difficulty of giving the drug, but at the same time, you know that it will be even more expensive. Right. Contraindications. Where do you think somatropin is contraindicated? Good. Diabetes in general, okay, and particularly when you start having the complications of diabetes. And one of the earliest complications of diabetes is retinopathy, okay? Whether the active proliferative retinopathy or even the severe non-proliferative retinopathy, that's an absolute contraindication for the use of growth hormone because, again, the patient is having the complications, and that's when diabetes is extremely hard to treat, okay? But where else is it contraindicated? Yes. Pardon me? Okay. That's a good point. In obesity, so if a diabetic patient is obese, yeah, you don't use it. But if the patient is having a growth hormone deficiency or short stature and he's obese, would you use it or not?
احكي عنه
عجبتني هاي إيجابيات وسلبيات. Yeah. Okay, that's a good point. So if we have, now the guidelines say that if you have a morbid obesity, so the body mass index is more than 35 or something, that's an absolute contraindication. Do not use the growth hormone. Now, if you have a child having a growth hormone deficiency and he's a little bit obese or overweight, you could use it. Again, as he said, because it's going to shift this metabolism into more use of fat. Okay, so that's going to be okay, unless we have a mentally retarded patient and having growth hormone deficiency. We have, for example, a syndrome called the Prader-Willi. Okay, we're going to discuss it later. To be. The steak story. يسموه يعني the funny child. Okay, أول واحد حكى عنها وصفها تشارلز ديكنز بواحدة من his stories. بعدين إنه it was known as a syndrome. Anyways, إنه هذول they are children. They have some sort of mental retardation. They are obese. Okay, and they might also have growth hormone deficiency. In that case, you do not use it. Because the eating systems and lifestyle will not change, okay? For that patient, he's going to stay at home doing nothing. And in addition to that, we are afraid of something I'm going to mention in a minute, okay? Just wait for a second. Right. The first one as a contraindication is actually growth hormone. So you have to know that the Olympic anti-doping committees, they test for this growth hormone frequently. ماشي? If it's not for a medical reason, so Messi is not banned because it was for a medical reason, a medical condition. Diabetic retinopathy, that's another thing. And the important thing, if you have the child with a closed epiphysis. Okay? Which means what? There will be an induction of the bone growth, but at the same time it's a closed epiphysis. So that means that there would be derangements in this bone growth. So it's contraindicated. Another thing which is also within a closed space is the brain tissue. Okay? So if the patient is known to have an increased intracranial pressure for whatever cause, it's contraindicated to use the growth hormone. Now, whether it's related to the induction of the growth itself within a closed space, that could be an explanation. The other thing is that from our practice, we know that given the growth hormone might induce the fluid retention. Okay? So induction of this fluid retention within a closed space, within a space that has an increased pressure already, it's going to complicate matters for the patient. So it's contraindicated. ماشي؟ وين؟ Okay, because of one fact, which is the increase in the lean body mass. We know in these cachexia conditions, like in AIDS, the wasting of the muscles is something very bad for the patient. يعني هو مش ناقص. With the wasting of the muscles, everything will be better. So one thing to treat such wasting is to give the growth hormone targeting an increase in the lean body mass. Now, the effect on the cartilages, okay, that's going to be good. The effect on the bone, it's a closed epiphysis, so you have to be very worried about that. But we know that the balance is towards increasing the lean body mass, mostly when you give the growth hormone in these conditions. What? Both. It could be related to the chemotherapy, but some types of chemotherapy, not all types. It could be related to the psychological status of the patient having cancer. It could be related to the cancer itself if it's affecting, for example, the hematopoietic system. Okay? So all of these factors. But, somatostatin. This is an interesting thing, and it's extremely hard to understand for a reason or another. We know that it affects the anterior pituitary, leading to the inhibition of the secretion of the growth hormone. But at the same time, we know that it inhibits also the secretion of the thyroid stimulating hormone. Right? That's manageable. The other thing is that we know that it's secreted also frequently from the pancreatic cells. Now, these pancreatic cells within the vicinity of the islets secreting the insulin and glucagon, we know that the secretion of somatostatin will inhibit both systems, which again does not make sense. If you inhibit insulin, how could you inhibit glucagon also? We will come to that in a minute. In addition to that, it's just an enemy for any type of secretions within the digestive system. So first off, it inhibits the release of VIP. Okay? This VIP, the vasoactive intestinal peptide, we know that it increases the blood flow to the intestine. If it inhibits that, it's going to inhibit the blood flow to the intestine. But that's not the only thing that happens. Any type of secretion from the stomach down into the intestine will be inhibited. Gastrin, hydrochloride, cholecystokinin, you name it. They're going to be inhibited by somatostatin. So in a way or another, it resembles one condition, which is what in the GI system, since you have just finished that system. It's the malabsorption syndrome, okay? In a way or another, it's inhibiting this emptying gastric activity and intestinal activity, so that's going to lead to a picture similar to the malabsorption syndrome. Okay? Now, somatostatin is not used clinically for two main reasons. The first one is that it has a too short half-life. Even when it's given IV, it's just a few minutes. And the other thing is this fact. It produces just too much insulin effects. And when I say insulin effects, it means insulin inhibitory effects. So it inhibits insulin more than inhibiting glucagon, which again does not make sense because it inhibits growth hormone. And growth hormone is a counter-regulatory to insulin. So if you inhibit growth hormone, insulin should increase. And how does it inhibit growth hormone? And then it has a minimal inhibition of glucagon. Okay, in general, just a second. If I want to say what is the effect of somatostatin on the glucose system, give me one word to describe it. Or the result of the effect of somatostatin on the glucose metabolism. It's called dysglycemia. When in clinical practice the word is used, this, it means nobody knows which case will happen. Dysglycemia, because we know sometimes the patient will have hyperglycemia, okay? Sometimes the patient will have hypoglycemia. Now, is there a clear cut explanation for that? Not really. If you remember from studying the autonomic nervous system, you remember dopamine, and dopamine could have several effects on several types of receptors, but we know for sure that in clinical practice that the dose of dopamine will decide which type of receptor will be affected. Okay? Is it the case with somatostatin? Again, it's not clear-cut. Nobody knows it. Anyways, we know we cannot use somatostatin, so we had to produce an analog, and that analog, from its name, octreotide, it's an octapeptide. Okay, octapeptide of that somatostatin. Where would you use it? What conditions would you use it in? Okay, so he said upper GI bleeding. That's one. What else? From? Okay. Which is something we call secretory diarrhea or VIPomas, for example. The increase in this VIP. What else? From this lecture. The effect on the growth hormone. Where would you use it? Exactly. So in cases of acromegaly, you could use this type of treatment. Compared to the somatostatin itself, it has a longer half-life with a higher selectivity, which means what? It has in tumors. It's given subcutaneously, okay, but we have also now the depot preparations, which can be given once per month. The indications for that are acromegaly and VIPomas mostly. Now, it could be used in the clinical setting for the treatment of upper GI bleeding if it's coming from a defined source, like esophageal varices, for example. What are the expected side effects of this drug? VIPoma, what is the presentation of VIPoma? لكن خاصين فيها. لا مش للدرجة دي. مش للدرجة. Yeah. Now, with VIPomas, mostly it's diarrhea, okay? But it's a secretory diarrhea, which means that it might have also like blood and something like that. At the same time, side effects of octreotide are related to what I mentioned in a minute, which is the malabsorption-like clinical picture. Which means what? The patient will come complaining of diarrhea, flatulence, and steatorrhea. because the patient is not digesting the food, is not absorbing the ingredients of that food, so it's a malabsorption. At the same time, it also inhibits the motility of the gallbladder, okay? And that leads to gallstones, okay? To the production of these gallstones. ماشي؟
ما بتعمل بس الغسيل.
أعتقد إنه آخر دور بنحكي عنه مش رح نحل البرولاكتين. طيب. Now, the last thing to talk about in the growth hormone system is this drug, the growth hormone receptor antagonist. It's a growth hormone receptor antagonist. Okay, keep it in mind. It's called pig-bismuth. Now, when you see this PEG in pharmacology, it means there's a drug, and we added polyethylene glycol to the drug. Okay, polyethylene glycol. There is an explanation for that, but we're not going to go over. Pig-bismuth. Now, the mechanism of action is that it blocks the receptor of the growth hormone. So what's going to happen? The mediated release of somatomedins, IGF-1 and 2, will be reduced. Now, the important thing about it is that it has maybe higher selectivity for certain growth hormone receptors, and that's why it could be used efficiently in resistant acromegaly. That's possibly the most important indication for this. So if I have acromegaly as a state, what's your first choice? No. Octreotide is your first choice. Now, if it's a resistant type of acromegaly, you might not target the growth hormone itself, but target the receptors that lead to the production of IGF-1 and 2. And then you take pig-bismuth. Now, the side effects of it are not that common, okay, and not that bad, except for one, which is the liver toxicity. It's not something you see very frequently, but we know for sure that it could affect the liver function, so you might need to do it routinely, testing the liver function test in these patients. As a summary, in the growth hormone deficiency conditions, like in the pituitary dwarfism, what would you use? Somatropin. Okay. What else? مين؟ حكينا somatropin. شو كمان ممكن تستخدم؟ ترى اسمعوا كل الأربعة دي اللي حكينا. Somatropin and thermoretin. وين يقعوا؟
هينا يا دكتور.
شو الثرموريتين؟
قول له growth hormone releasing analog.
growth hormone releasing analog.
طيب عشان هيك أنا حطيت هذا second choice. It's not your first choice, okay, and we explained why. In the cases of an excess of growth hormone, like in acromegaly or in gigantism, the options you might use are octreotide. This is your first choice. Could you use somatostatin? We cannot use somatostatin in clinical practice. We use the analog of that. Or if it's a resistant type of acromegaly, you might use something to target the receptor itself, and that is pig-bismuth.
دكتور
يلا اسأل.
دكتور الأخت مش عارفة ألفظها. المهم ما إلها السايد إفكت الديسجلايسيميا؟ من أحد السايد إفكت ما ذكرتهم الديسجلايسيميا.
Okay. Now, yes, it could lead to dysglycemic control, okay? But I mentioned what's most encountered, most frequently encountered in practice, which is the malabsorption like clinical evolution. But that's good. Which means what?
What?
Which means that you have to be cautious in using such a drug in patients who have diabetes or patients who have glucose intolerance. And something like that. Yes. Okay. IGFs mostly they might act on the insulin receptor themselves, okay, because they are structurally related. Now, if you act on the insulin receptor, that's going to lead to what? To an increase in the glucose uptake by cells and increase in lipogenesis, which is opposite to what the growth hormone does. Now, how do we like differentiate between these effects? Now, the fact is that the IGFs are targeting some specific structures in the body, particularly the cartilages, okay, and they could produce their effect. They don't go too much to the adipose tissues in the body. They don't go too much to the, or they don't have too much effect on the glucose metabolism itself, okay? Unless you give it in way too much dosage and for a very sustained and continuous manner, that means that it could start producing the insulin-like effect, which is counter-regulatory to the effect of the growth hormone, which is in another way, they will have a negative feedback inhibition on the secretion of the growth hormone itself. How do you understand that? Simply, growth hormone comes down from the pituitary, produces certain effects, okay? One of these effects is to go to the liver and induce the production of somatomedins. Somatomedins will start the negative feedback on the growth hormone, and they might not last way too long to start producing the insulin-like effects, okay? But if you have a growth hormone secreting tumor, which means that it's not coming from the hypothalamus, the growth hormone is secreted from outside, okay? And that will keep giving somatomedins. Somatomedins will have the negative feedback on the pituitary, but the growth hormone is not coming from the pituitary. It's coming from a secreting tumor. That complicates it. Endocrine, by the way, is in practice. يعني اللي بيروح يتخصص endocrine لازم يكون مبسوط. It's a trial and error practice. They don't know facts. They don't know like, yeah, if you give this is not gonna happen. No. I bring Joanne, I give it a try with a certain dose of a drug, and wait. نشوف شو بصير. صار bad بنقلل الدوز. منيح بنكمل بعدين. ترجع لي بعد كم شهر برضه بعيد نفس الكونسبت. You will see it. Again, ليش? It's because of the complexity of the system. The several organization steps within the system. But that makes it fun to study. And to have questions and things. Any further questions? Okay. Inshallah, يوم الاثنين, I guess, we will continue with the prolactin and start with the thyroid system. Thanks.